Think we are live. There we go. All right, it worked. Man, let's see. I know some people are going to show up. Some people are trying to come over. It's a little bit better camera, I think, on my laptop too. But let's see here. There we go. So I think that went out. I know it takes a minute for people to come on. There we go. Hello, Anthony Kelbell, Kathy Brady. Hey, hey, hey. People are showing up. I'm glad you guys could find your way over. Very cool. Now some people. One Harley, Amy James, Dep Lepley, Seaview Coaches Dublin. Hi from Dublin, Ireland. So cool. Good one, Susan. Hello again, Susan Irvin. Thanks for coming. Thanks for sticking around for a couple minutes and coming over. I appreciate it, guys. Jen W, Jean McKeekren, I think it is. Anthony C, Evelyn Malone. Monica's here, all right. And Kathy Sanders, Cheryl Stevens, Sandra Reed. I'm so glad you guys could find it. I know we had like 250 when I just went on my main channel. I know it's going to be less here, but as the video goes up, people will start to discover it. Because I really want this to be the long form area we can do questions and answers. Sissy Albright, Susan Flaherty, Karen Appleby. Good one, Susan. Hello again. Kayla, Sandra Reed, Andrew Coop. Want to shout out everybody. Virginia M. Nearly. I almost got it, huh, Gene? Donnie to the max, Sissy Albright. All right, we're getting up there now. So I wanted to do. I wrote down a bunch of questions that people had from the last two videos I did, and I know it shouldn't be hard to find Mr. Popsit Live, Kelbell, but you know I've had issues with what's called shadow banning. When you go to search something, if you don't type it in exactly correct, it will not auto-populate and come up. Hello, Laura. Thanks again so much. I've had issues with that, and so it's been tough to grow something. And this channel's fully monetized, so it does get ads. So once this video goes on there, it does get some ad revenue. It doesn't get obviously the same amount of views that my other one gets, but as that grows, that at least lets me pay for the ridiculous amount of CPA fees and lawyers fees that it is just to keep a channel going, which I had no idea when I started it. It's crazy. But I do think it's kind of tricky. But as long as, you know, I just keep putting it out there, people will be able to find it. And I think it, yeah, I'm going to link it on the other channels too. Oh, thank you. Have to support both channels, Laura. Thanks so much. I think you're my biggest supporter, Laura. So I really appreciate that. So, what I want to talk about, I did two videos in a row, and I did it on purpose, and they were actually fairly old videos. I did the large neck cyst right here, and that was I wanted to tell a little story on that. Oh, super sticker, gamer girl, thank you so much. Very cool. Controller, oh yeah, broken arm. I'm so sorry, but thanks for the support. So I wanted to talk about that big neck cyst. He actually came in for something else. I think it was hand eczema. And he kind of turned his head, and I saw this giant mass on his neck. And at first I was like, man, you have thyroid issues. And he's like, no, I just had this bump here of like 20 or 30 years. And I was like, you know, we can remove that. It's just going to keep getting bigger. And if it does pop, it's going to become an issue. You know, you get a large abscess there. It's really not fun because you can get some pretty bad swelling that will push on, you know, your trachea and cause breathing issues, all kinds of stuff. So he was like, yeah, I got it scheduled, but I'm really scared I might cancel. I don't want to be put under. And they were going to put him under, which, you know, it was big enough. That's not a crazy thing to do for that. But I checked it, and it was so shallow. It was right there at the surface, but it was just large. But I was like, you know, I could get that out fairly easily. You don't have to go under. We can just do local anesthesia. And he was like, really? He was so blown away. And so I was like, yeah, let's do it. And he actually scheduled. Now, he had, I believe, kind of a large deductible. So that really saved him a lot of money because having a full surgery suite and the anesthesiologist, all of that. Oh, super chat, Michelle Temple. Thank you so much. I appreciate it. You guys are awesome. So, just a local regular excision is way less than a couple $1,000s it would cost for an ENT specialized surgeon, to go under that. Was it in a little bit higher risk area than if it was just in the shoulder? Yeah, but not bad. Everything that's important is well underneath, down below the muscles there. We're not even going down to the muscles. So, that was a fairly easy surgery. And that was a fun one. And at the end of this, we're going to go and show his follow-up, which he was so happy. So we're going to go over that and then answer any questions that I don't answer on this. The second video, which I talked about in his video, which was from almost a year and a half ago, actually. I didn't post it because there was no pop, but it was relevant here with that video because they were the same size growths within a couple inches of each other, and I wanted to show how things present so similarly sometimes. It's a common thing. And what he had, the second video, which was the last one, was a pleomorphic adenoma on his parotid gland. We have a couple of gland under here, one up in the roof of the mouth, and then the parotid gland, salivary glands. And you can get this benign growth, and sometimes they actually can become cancerous. So it is important to get them out entirely, but those are not even close to a cyst. Pleomorphic adenomas typically go a lot deeper. They're wrapped around a nerve, especially the one on the parotid gland, can be wrapped around a nerve there, which can cause all kinds of issues and some deeper vessels. So they are a benign growth, and on talking with him, he was like, it's been 5 or 6 years. It had been quite a while. Oh, Kathy Brady, thank you so much for the super chat. We did telemedicine during, it's a good question, Kathy. We did telemedicine during COVID, but they have kind of stopped it now. The regulations were loosened, and then they kind of got strict again. So you can call and we can see if we can set it up. I know we still do some, but I think in and out of state there is some regulations about the provider in whatever state you're in, or internationally it's even more difficult for me to be able to write prescriptions in the state you're in. There are some difficulties to telemedicine on that. If you're in the state of California, it's pretty easy. I actually can. And I've done several. I did several during, lockdowns and all that, but they kind of changed it back since then. Elizabeth, that's very cool. Oncology fellow. Thank you so much for the compliment. So, talking about that removal of the pleomorphic adenoma. So he did not have insurance. This is the last video I'm talking about because there's 2 different videos we're discussing. And he had that 5 or 6 years, so that's part of his history. I did not think that it was cancerous because of that. So cancer tends to grow a lot faster than non-cancerous lesions, usually. Not always, but usually. So when we have something that large, that firm, anytime you always think, well, could this be cancerous? But 6 years being there, he would have been a lot worse state usually if that was any type, especially a poorly differentiated squamous cell carcinoma, which is common there with tobacco users, and that can be very bad. So, but I have seen that before. I have seen it before. So the questions become, okay, he's a cash patient. He's not going to pay an exorbitant amount of money to find out what it is. He's not going to go in for ultrasound guided fine needle biopsy. He's not going to do that. He didn't have the money for that. So, and that's why it had been so long that it got to the point that it did, because they had recommended, the primary care recommended that. And he just like, I don't have the money for that. So imaging, just even getting an ultrasound or an MRI, on cash patients, a lot of times they get priced out, unfortunately. And that is a United States thing. And, it's not great, but it's a reality that as a provider, you're going to have to deal with. I liken it to kind of medics at war. they've run into something, there's an explosion, you've got artery pierce, something like that. You do the best with what you have at that given time. And so there's a lot of medical providers that deal with that over the history of medical providers. And, you know, in a big city like Los Angeles and in the suburbs surrounding it, we have a lot of things to utilize that are great, but there's still a lot of people that fall through the net, and it's extremely unfortunate. But it's where we're at. And so, you know, I could sit there and say, hey, sorry, or, you know, out of imaging, fine needle biopsy with imaging, or fine needle biopsy or sample, and then excisional biopsy, which is what I did. Those are some of the options that you have there. And excisional biopsy is easy. It's easy. It's what we did. You make a little cut. We were going to go in for something more, but then the second, you know, you start going down, you know, this thing was right by the surface. There wasn't a risk of getting a big artery. Hey, hello, Scotty. He made it. He doesn't make the later ones sometimes. Very cool. Thanks, Chef CC, also. I try to stay up, but I know it goes kind of quick here sometimes, but on the comments. So with those options, man, I got eviscerated on the comments. And a lot of you, I know the ones that are here were backing me. Some very, very cool comments I saw also from medical professionals that do excisional biopsies all the time that were kind of backing me. I appreciate all of you because there's a lot of you on this channel. But there was a ton that were like, man, how do you go in blind? We always go in blind. You know, things are usually cysts, but not always. So, you know, ultrasound's not super expensive, but having the machine, there's a cost with that. So if I were to send him the ultrasound, it would definitely be way more than an excisional biopsy. And, you know, it's not that you're not completely uncertain on these things. Likely a cyst, lipoma, or some type of growth for sure. Thanks, Dave. So, you know, you're not going in completely blind. And so this brings us down to understanding your landmarks. When you're a professional and you do this all the time, that's why I don't go off on people who are trying to eviscerate me that aren't in the profession, you know, aren't in medicine, and they just want to come on and be a troll or say some horrible things. That's why I like this channel. That's why I do these videos. So, you know, you're getting just a little window of a small procedure, and then you can get a 30 to 60 minute explanation of it here, which I think is cool, and I enjoy doing it. And I think it's important for education. So I know, thanks, Kayla. I did see you on there also. I did see you there, and you had some great comments. I appreciate that. So when you get into that situation anytime that you're in there. Charlotte, thank you so much. Yes. Go Bucks. Very cool. Thank you. So anytime, yeah, we go in blind anytime something's below the surface. That's exactly right, Gamer Girl. Anytime you have this, understanding your landmarks is very important, but if you're a professional and you're doing this all the time, you already understand the landmarks and what you're dealing with. Of course, this is a higher risk area. We have a ton of stuff in that area. And I have had patients come in with very deep lesions that I assume were thyroid growths, or, you know, a lymph node, lymphoma, types of things like that. And I can feel, I'm like, wow, this is way down in there. I can't do that. And those people absolutely do need imaging, at the very least, a fine needle biopsy. And not to say that there's no risk with a fine needle biopsy. You know, when you're going with a needle, they're ultrasound guided, but you could pierce something large, a large vessel with that. You know, at least when I'm doing an excisional biopsy, and I did cut a small artery you saw there, I can go in there and I can cauterize that and stop it or tie it off. I haven't really had to tie one off on my channel. I do tie them off, but not in any of my videos. I haven't had to do it on a video, but it happens. Put in a dissolvable suture on a medium size, small to medium size artery. Just do a little figure 8. Tie, cinches it down, stops it. No big deal. So that happens. And yes, surgeons perform exploratory surgeries all the time. So I know when people were talking about that on there, that's why I don't get mad. You know, these are people that really have no idea, and that's what my channel's for. If I was coming on this channel to try and educate, and then I just shouted down people who had something to put in, it's not a very good channel, I would say. So, so yeah, I welcome that, and it was those questions are great. So knowing your limitations, absolutely. Knowing what you don't know is huge, huge, especially for mid-level clinicians, nurse practitioner, neck person, hello, nurse practitioners, and physician assistants. We get a lot of information in a short period of time. The DOs, MDs, they have a way, they pay a lot more for their education. It's a lot longer. They go in more depth on the things that they need to concentrate on. So yeah, sometimes when we get out, there's still a lot of learning, and you know, in medicine, you could learn your whole career, but there's a curve for mid-level clinicians when they get out, and it's an important thing to find somebody who will take the time to teach you. And I talk about that all the time, but yeah, that's part of that. So the bigger question also, and I think this is kind of an underlying thing here, is the overutilization of medical resources. So the overutilization of medical resources is, I think, probably one of the number one things. Beth Warner, thank you so much for the super chat. One of the number one issues that the American medical system is getting into. Karen Inman, thank you so much. Pair character dancing under rain, that's awesome. Thank you for the super sticker. Appreciate it. You guys are amazing. And I say this as an umbrella, overutilization of medical resources. There is a lot of reasons that happens. And so it's not something that you can just say in one sentence why it happens. But there are some providers out there that are trying to make more money. Absolutely. It is set up in a system where the more you do, the more you make, and that's unfortunate. There are a lot, I would say the majority of providers are just trying to know what's going on when they're using medical services. However, there's a lot of litigiousness, suing sometimes. And so a lot of people are trying to cover their behinds, and that is very big. So, and what it does is you're doing all this stuff to try and rule out things that are zebras, that are 1% chances, because you're so scared to miss it, because if you did, you're going to get sued, and you could, get a ding on your medical license, or even, lose your ability to practice. And then it's unfortunate. It's just the system we're in. And there's a midline in there. I believe that most people, the vast majority providers, fall into, if they're just trying to be sure or to back their opinion of what they think it is, and that's great. But there is an overutilization. I think most of it's from a litigious side. However, so in this instance, just in this particular instance, everything that people said would definitely be on the plate, and I think they would be covered by the insurance. However, when you're that provider and you're right there and you're like, okay, this is real shallow, I can make a small cut there and I can take a piece of that and send it out. That guy was so happy when he got the path report back that it wasn't cancerous. And I had already talked to him. A lot of people, I also had a lot of people say, how dare you say that could have been cancer to him? And I have very honest conversations with my patients. And I also evaluate what I think they can handle. Have there been patients where I thought it was cancer and I said, let's just wait for the path, and I didn't say the cancer word? Absolutely. Absolutely. I have patients that I can see when they come in, they have white coat syndrome. They're barely breathing, just being in this chair and just seeing me come in, if I'm wearing my white coat. And so, you say cancer to that person, they're not listening to anything you say after that. So, these are things where they're coming to get an answer. They're coming for a biopsy usually. So the answer is going to come within days to a week or two at max. and we get the path report back. So, you know, there's a time and a place. This particular patient, I'd already talked to him about it. Very cool young guy. Actually, I don't want to say too much. He's kind of in the music industry. So we had a long conversation about music and recording and guitars before any of this happened. Very cool guy. And so when I opened that up, we were just continuing our conversation that we'd had off camera. Yeah, there's a chance it could be cancer. I don't think it is because it'd been there so long. There's also a good chance, and I think that it could have been benign, which it was. So, that turned out great. And just for the people who were saying those comments, he actually did come back fairly quickly afterwards, and he had scheduled his surgery. I have not seen him since then, actually. So a lot of times when things go well, these patients go off into the ether and you never see them again until something else comes up. He's a young guy. He's probably not going to have something for quite a while. But that surgery that he was going to get is a more serious surgery. I do know of several patients that have had it and have nerve damage in the area. It goes right through some nerves there, and there are some risks to that. So people need to be put under for that surgery. That's not something I could do in my office. And I knew it the second that I cut into it. And that's why I usually drain my cyst as well. A lot of people ask that. I usually will poke it and push to see the contents because the contents confirm before I start digging deeper. Because a lot of people are like, oh, you're just trying to pop it. That's so rude and disgusting. No, it's actually to confirm what my thoughts are going in blind, when there's something under the skin. So that's an important thing. And so that overutilization of medical resources is something a lot of students that are on this channel, as you come out, and you're new, you're like, well, gosh, I don't know. I need to confirm a lot of these things. Those are the things that make insurance prices go up for everybody, that book out procedures, sometimes weeks or months at a time because they're so backed up because so many people are needing to get those procedures. So I just find it as a responsibility as a medical provider, and the ones of you that are on here, for sure, that'll be something that you're going to run into, and you got to just make those calls. And when you can lessen the burden at all costs, I do, and you should as well. So long story short, that's what I was getting at. Lessen the burden for the patient, lessen the burden on the medical system, and I always tell people when they come in with all these medications, I want to get you clear or better with the least amount of things that you have to put on your body or take in your mouth as possible. So a lot of times when they're really severe, we'll hit them kind of hard and then start taking medications away to see if they're stable. Psoriasis is an example of that. Hidradenitis suppurativa is another example of that. So we have a lot of options there when we're choosing and to go up or down. That's why we do follow-ups and kind of make those calls. One other thing was the melanoma video. My melanoma patient, and those of you that have been with me for a while, it's an older video. You can find it. It looked like a cyst. It had been there a little while, and so we went in and I cut it open, and it looks like a black, wet lump of coal. And I was like, oh boy, that's most likely a melanoma. And you can see how we kind of talk about that in that video. But that's a perfect example of, if I did a fine needle biopsy on every cyst that came in, I might catch something like that melanoma or even a squamous cell, poorly differentiated squamous cell, maybe less than 1% of the time. But if I was utilizing all of that every time, that would be an overutilization. So a lot of people are like, why didn't you do that? And that's why. And just for the follow-up, I think I might have talked about it a little bit after that melanoma on the back that we took out, which was large. I don't know if I had told all of you, he came back in with 30 metastases on his chest and head. Little spots. He was good for about 10 months, and he had PET scans that were negative. And he had all these little black spots coming up, which I have seen time and time again with my melanoma patients. The good news was, and we had talked about it in his video, that he did have the mutation that was amendable to taking the medications. So I didn't see him for a while. He went to the oncologist. They got him on these medications. He had some regression. I saw him one more time, and then I didn't see him for about a year. And I was pretty worried, actually. And he came in just about a month ago, and he paid cash to come see me because his insurance wasn't accepted. He had changed his insurance, and there's, contracts constantly go to different dermatologists or different areas, different derm companies. And he was no longer under. And I was like, no, he just came in to say hi and give me an update. And I actually gave him his follow-up money back and just wanted to thank him so much. And he's doing great. So it's staying it's holding it back for now. He's had a couple different treatments. They've had to switch it a couple times, but he's still charging forward. And I, prayers and for him. So I want to thank him for following up as well. So that was, everything that I kind of had to talk about in that large neck cyst. Let's see the follow up real quick here, and then let's do a couple questions, and then we'll end it. Here we go. Yeah, BRAF mutation inhibitors. Here we go. Make me small. There's the stitches still in. This is his 2-week follow up. Here we go. Guys, this was our large neck cyst that we took out. You can see that tissue version. It's all still puckered up. Once we take these stitches out, that'll flatten. And the hair is kind of growing in there. It gets a little pink and red because it's irritated. There's a lot of hairs that are kind of curled up in there too. So once we unravel this running stitch, everything will get a chance to breathe, and then the redness will go down in about 4 to 5 days. So thanks to him for sharing. Great removal, large cyst that they told him he had to be put to sleep for. But we got it done in the office, minimal pain, and it turned out great. So thanks again for sharing. Thanks for popping by. Okay, guys, this was the very large. You can see here, you can remember it was a large epidermal inclusion cyst on the neck, and it went pretty deep. You can see it has a little indent, but it's starting to fill in. Little bit of a hypertrophic scar where you can see the scar is a little puffy. That should go down in the next 6 months, hopefully. If it doesn't, we would inject it. But healed very well as far as how big and how deep that was. This looks great. Thanks to him for sharing. I always like to show this is 3 to 4 months out post-surgery. So he's looking good. The pigment's kind of going back to normal. And we just monitor that cut line. If he gets a little hypertrophic scar, we'll put some Kenalog in there and that'll flatten that out. But that happens sometimes when there's a lot of tension or there was a lot of pushing or kind of inflammation on the skin. The scar kind of gets puffy for a while and then goes down. So we'll keep an eye on it. Thanks to him for sharing, and this will be tagged at the end of the video. There we go. So that reminded me a couple questions that came up about his area and shaving as well. So yeah, he healed great. He was so happy. He was so excited to see his video too. So he'll probably see this. He was a fun guy. He was very talkative. I think he was nervous, but so yeah, that healed great. He possibly have a little hypertrophic scar. Sometimes it peaks up and then it'll start to soften. We can inject that. We can inject it with Kenalog and that will go down. And Scotty, yeah, the philtrum right here, sensitive area. There's a couple areas all through here that will instantly make your eyes water. But I am gonna do another acne video about extractions. I have on Tuesday an amazing patient coming in as far as extractions needed, and we're gonna do them. So he's coming in. It's going to be a great video, and then I'm probably going to follow up on his video to talk about extractions way more in depth because I think it should be talked about. There's nothing is one size fits all. That's all I can say. Teresa Hansen, hello. So I want to just do a couple quick minutes. If there was questions that I didn't answer, you guys can do those now, and then we will will conclude. I think we're going to go on a little hike. It's starting to rain a little bit, though. I don't know. I'm still on, Kathy. Yes. I know it's hard to tell when you're watching it if it's live or if it isn't live, because I see a lot of people that go on and they ask questions. I try to go back through and get those too. But, oh yeah, got you. Very lucky. Thank you, Nancy, so much. How long did it take you? Yes, Elizabeth, good question. So as far as suturing goes, I found very early that I love suturing. And I found that on my ER rotation, which was my first rotation as a student. And some guy was putting a ladder up. One of the ladders that kind of you can extend with a rope and you click it down was rope broke, and the ladder just came down fast and sheared his palm off. And it just flapped it down all the way around here, and it was hanging down here. Now, they had a hand specialist come in, and this is the dangerous side of the hand, obviously. This is where a lot of the nerves are and everything. And everything was okay. He could move his fingers. It just flapped his skin. And so he was like, the guy was on call, the hand specialist, and, he was like, this just needs stitches. I don't want to sit here for an hour doing stitches. I was in another emergency. Do you guys have a student here or something? That's what he said. I remember hearing him say it. The ER doctor was like, yeah, I got a student right here. And he said he could suture. He's like, perfect, get him in here. And so I went in, and it was just little simple interrupteds. I think it ended up being 58 or 60, right around there, all the way around his hand here. And it was interesting because his wife was there, and I got to know the guy. We were just sitting there talking, it took a while. But before I was in that situation as a student the year before, I got two huge pig hips or shoulders. I guess it's a pig shoulder. Skin very similar to ours. And I probably did, I would say, 80 to 100 closures on that pig. I got two different ones over a 4-month period. And I went on YouTube. And this was before I got into my rotations, and then was able to have doctors in real life show me. And I did all the different closures and flap closures, all of that. And I think that's important as a student if you really want to do a lot of sutures. By the time I was sewing human skin, it was my 120th time probably. So it was not my first time or my second time or my fifth time. And so I really am a stickler, kind of. I'm a little hyper vigilant. If something's not right, I usually will cut it out and just realign it. If it's off, I want it to look good. My eversion, the closures, everything. And that's just kind of being obsessive compulsive, which I don't think is a bad thing when you put it in a good direction like that. So yeah, that's one reason why I remember when I did my first sutures with MD on my rotations, he was like, wow. He's like, how many times have you done that? And I was like, probably 30 or 40 on pig. And he's like, oh, that's good. So I'm going to have you do a lot more for me. And so he felt, more inclined to let me do some very cool closures for him, even as a student, right there saying, yeah, I like that. You try this, try this. Once you show them that you put in the time, they're like, wow, this guy wants to learn. Great. I would love to utilize him and show this. So, yeah, and that's how it just went. And then I worked, my first couple years in dermatology, we were alongside a lot of plastic surgeons. Sometimes we utilize them for bigger closures post Mohs. And man, getting to see them do the closures, having them show me some of their techniques, it became something, it's a lot of it I don't utilize. I can do transposition flaps, double advancement flaps. I can do all those. I just don't need to usually. There's no reason to. I'm doing simple excisions usually. So, but it's fun to know them, and I could do them. I have done some bigger flaps on the back on big cancer removals. Sometimes I'll do a transposition or a double advancement sometimes, depending on where it's at. But it's 1 out of 5,000 or 1 out of 2,000 that I ever need to do. But good question. And thanks for noticing. I put a lot of time into the sutures for sure. So let's see here. I see. Oh, man. So sorry, Kathy. They said they did Mohs, but one deep removal and said it was all clear for me. The shots were painful. Yeah, Mohs, Rebecca, is a very common thing. We do a ton of it. The short version of Mohs is if you're anywhere else, below the neck, you can do an elliptical excision, which is kind of like a cat eye wedge. You can lose the skin on the edges to help make the closure better. On the face or the nose or the ears, you don't have a lot of extra skin to lose there. It's very tight. So you want to take just what you need. So they do circular cuts a lot of times. And those circular cuts, wait a second. I think I had a text there I had to get. Those circular cuts are just what's needed, and then they can either do a skin graft, an advancement flap, secondary intention, let it fill in on its own, but it saves as much as your skin as they can. So, and that's why Mohs surgery was invented. The dermatopathologist is there that day. They do the cut, they prep the slide, they tell you within a half an hour if it's clear or not. So that's kind of Mohs in a short version of that. But yeah, I know a lot of people have questions about acne, facial cleansers, what to use, those types of things. So I'm going to do a whole live just on that coming very soon. So look out for that. Because I think it's going to be fun. I also have a bunch of before and afters with acne and with lasers and some of the cosmetics that I do that I haven't really put much on that I'm going to put on my TikTok, and they're going to be coming as well. So you can see I'm going to kind of veer a little bit into that realm because a lot of people have a lot of questions on that. So I know. So let's see. Oh, thank you so much, Wendy. Yeah, I try to be educational, in the room and on here. I noticed when I was a student that sometimes medical professionals talk straight over the heads of people and just trying to use the correct terms and things. But I always made it a point that I would tell them the medical term that it is, and then I would kind of break it down in layman's terms as well, which is why I'm in the rooms a little bit longer than I should be sometimes, because I'm kind of, just want to make sure that people understand what they have when I have those interactions with them. So, but yeah, I appreciate that. I love that you guys appreciate it. It's been great. I mean, we just passed 350,000 subscribers on Mr. Pops It. And that's amazing. I never thought it would get that big. It did slow greatly when they demonetized me and kind of shadow banned me. And I kind of had a choice where I could have just stopped doing it. But I enjoy educating. I enjoy, going over the videos and sharing them and answering people's questions all over the world and making those connections. Because I think there's a lot of people in underserved areas, too, that they're learning something from it to know the right questions to ask when they go in. I think that's great, and it's why I do it. And maybe it'll grow into something. At some point, there may be a 15 or 30-second small ad of me just talking about something on my main channel that will help pay for all the stuff that comes along with having a channel like that. So, but in the meantime, Mr. Pops It Live and you guys being here has been great. It's starting to become something, and I can't say how much I appreciate all you guys. You make it fun to come up here, whether it's 100 people or 1,000 people. It's awesome. So, thank you, Micah, for the super sticker. So, really appreciate you guys. I hope you all have a great Sunday. Thanks so much for the love and support, and we'll do it again very soon. I have a couple things coming up, some great extraction videos, and I have I already showed one video of her, and she's been a great patient, but steatocystoma multiplex, the biggest I've ever seen, online too, and probably 150 of them, 200, all the size of ping pong balls. Those are coming very soon. It's a bunch of videos in a row. I'm trying to edit so I can kind of do them in a row so you can see as we progress. So I think you guys are going to be blown away by them. They're pretty interesting. So hope you guys have a great Sunday. And thanks again for popping by. Let's do it again soon. See ya.